Great. Well, happy Friday, everyone, and welcome to this Lunch and Learn focused on how to optimize acute soft tissue injuries. So we're planning to present for about 10 minutes today, and we'll have like a 10-minute Q&A afterwards. Excuse me. Also, one other thing, we'll stay after if anyone has any questions past the 20 minutes. All right, so Erin, Ryan, and I are presenting this information, but just want to say before we get started that we do owe our colleague Tyler, who is currently on paternal leave, most of the credit for championing this topic and updating our own practices internally. So thank you, Tyler. So our objective today is to relay a large shift in the evidence over the past decade away from treating soft tissue injuries with rice and towards this new approach. And so our objective with telling you this is kind of putting forth this idea that the guy who created rice actually came out with a blog post in 2015, and this was kind of a tipping point in the literature, basically saying that this term he coined is actually delaying healing. And in this blog post, he says, quote, "Coaches have used my rice guideline for decades, but now it appears that both ice and complete rest may actually delay healing instead of helping," which is pretty crazy to think about from the doctor who created this. And so we're going to move towards this peace and love approach, which Erin and Ryan will go into more detail in. But before we do that, I do want to set the stage for kind of the biology of healing, as there are four really well-defined. Priya, do you mind going to the next slide real quick? Four really well-defined phases of healing, and we can't really prevent the bleeding part. So we're going to focus mostly on the inflammation part. So I really want to direct your attention towards this phase. It occurs in the first 1 to 2 hours after injury. It peaks around 1 to 3 days, and it generally lasts for a couple of weeks. And inflammation feels like a dirty word in healthcare these days, but it actually serves an incredibly important role and purpose in tissue healing, and specifically soft tissue healing. So it signals for neutrophils and macrophages to enter that injury site. So if we jump in beforehand, it actually prevents these important proteins from entering the injury site. So the neutrophils help prevent those unwanted pathogens from entering, and they also engulf the damaged tissues. Also, if there's any bacteria in that site, it helps really kind of manage that. And then the macrophages come in and they kind of gobble up these harmed or unwanted cells. And that sets the stage for the phases of tissue repair.
Okay.
And so, yeah, rice kind of misses the mark just because it just impairs these later stages of healing, which has that cascading effect to those other two stages. So it's really the phase we want to focus on, and it's the phase we can make the most progress in, especially in the acute stage. So with that, I'll pass it over to Erin so we can dive into peace and love.
Thanks, Ben. So immediately after a soft tissue injury, we want to do no harm and let peace guide our approach. So we'll get into the P part, and we're going to relate this to like a grade 2 ATFL, so lateral ankle sprain that has, of course, been cleared from our Ottawa foot and ankle rules and sent to PT for some rehab. So in that first stage of healing, we really want to protect for up to 1 to 3 days. And the goal is that we're not increasing pain or aggravating the injury site. Now, keep in mind, this can be a little bit of a Goldilocks because we don't want to have so much prolonged rest that we're compromising tissue strength and quality. So in this example, we might have someone modifying their weight bearing a bit if they need to, but really trying to stay moving the best they can, work on good walking mechanics, probably not playing their sport for a few days, of course, but it's going to be really person specific, and it's going to be this kind of protected load phase. The next one is elevate. So E for elevate. We want to elevate higher than the heart to get that interstitial fluid out of the tissue. The evidence isn't actually a super home run for this, but it's a low risk to benefit ratio. So again, in this example, we might get that person's ankle above their heart a few times a day and work on some active range of motion. So still protecting, but getting some movement that way. In this case, it might be ankle pumps, some ABCs, some quad sets, and they might do that while their foot is above their heart. A is for avoid anti-inflammatories. So Ben so wonderfully explained this process earlier, why this acute stage initiates healing, and also can signal for later stages of the tissue remodeling. So if we use NSAIDs that affect this stage, we do know it can affect long-term tissue healing. So it gets into question of how we want to manage pain, which I think would be a good discussion at the end of this talk for all of us. I know in the PT world, we use ice for an analgesic, but that is what we use it for. So if someone's not getting pain relief from ice, it's not making or breaking our rehab. We don't just have people ice to ice. We'd actually rather have them have a more active approach and use that if it helps with pain management. And for the same reason, it is disrupting that acute stage of inflammation. C is for compression. So this is where we use external mechanical pressure to limit intra-articular edema. Again, there's the studies there, it's not a home run, but there is some randomized controlled trials that shows that when we use some compression after an ankle sprain, it can reduce and control some of the swelling and improve some quality of life. Again, we're trying to find that Goldilocks balance of getting some inflammation, but not overpowering that. And Ryan will get into that discussion with the love part. So in this ankle sprain example in the clinic, we used to use Tubigrip or an ACE bandage or something that just helps build some confidence during that time. E is for educate, and this is probably the most important, I would argue. But an active approach to treatment is key, and we need to let people know that. And we also need to let people know realistic timeframes and expectations. So in this grade 2 ATFL ankle sprain, it might be a 6 to 8 week recovery, and we need to let people know that. And we're also going to be moving through it. It's not just going to be not moving for 6 to 8 weeks. It's going to be working with physical therapy to get some gentle loading and exercises, which Ryan will get into. And how we educate people is so important. Having a positive tone, letting them know it will get better. It really helps set people up for success and avoiding unnecessary interventions, as there's really not an easy fix to this stuff. So the more we hear it, the better. I know when y'all refer to us and you've told people this, the expectations in that visit day 1 is just night and day. And we have research to back this up, so keep it up.
All righty, thank you, Erin. So after the first 2 days have passed, all you need is love. And I think the important thing to remember is that you're going to see some interplay between the different phases here. It's not like so compartmentalized that it's like, oh, only doing peace and now we're graduating to love. There's some things that can be done interchangeably, so to speak. And I think what you'll see with the love piece of this is that all of those things kind of build upon each other and have kind of cross effect on each other. So let's start with that first one, moving into L, which is going to be for load. I think maybe the easiest example is always thinking about Wolff's Law for strengthening bones and increasing the resiliency of that bone with load and tension and so forth. We need to have those same things happen when we're looking to strengthen our tissues, soft tissues, muscles, ligaments, etc. We want to establish maybe what that early pain guideline is for the patient. We kind of have it in our American culture, maybe that's like, oh, we want to avoid pain at all costs. It's like some pain is normal. And we want patients to understand that's okay. So we're going to load them appropriately, get them started with some exercise. That feeds into that O, which is that next letter, and that's going to be for optimism. Okay, pain neuroscience education is getting a big run right now, as it should. Patients like to know as we all know, patients like to know what's happening and why, so they understand what's going on. Mystery creates fear, creates that catastrophization, so forth. So we want them to see, as we begin that early loading phase, ankle sprain, whatever, we have them doing something so they can start to see those little wins that'll start to build upon each other. So the next phase would be V, and we're thinking about vascularization. So obviously that can feed into our optimism as well, right? If we can, even if they have that ankle sprain, are there other exercises that they can do? Can they go do their upper body workouts? If their ankle's okay, can they go swim? Can they do some biking? Anything we can do to keep the blood pumping. Blood pumping, not just for the brain, just for our mood and so forth, but also because so much of that nutrient and exchange of things back and forth at the injury site is, it requires that muscle pump. Get the waste products out of there, new things are coming in. We certainly don't want things to get stagnant. And the thing to remember here also, we know that exercise improves our tolerance to pain. So just by remaining more active, getting that vascularization, that's going to bring the pain levels down all by themselves without any drugs. So lastly, kind of the exercise piece, I kind of snuck in the rehabilitative part because I think that's where we come in. We want that early exercise. Like Aaron said, it's not 6 to 8 weeks of just chilling and laying around. It's 6 to 8 active weeks. In our ankle sprain example, yeah, we want to start getting that ankle range of motion back. We want that dorsiflexion to come back immediately. We need that in order to normalize the gait cycle. We need to get them slowly more and more comfortable raising up on their toes so that, essentially we just want to reduce the risk of other compensations elsewhere in the body as a result of this injury. We don't want the compensation to become a new injury itself. So again, ankle sprain part, if we just let them sit around, more likely to end up with a chronic ankle instability here. So we want to just be more active, get them started as soon as possible. And then, so that kind of brings us to the clinical bottom line. What is actually different here? So you can still see that there are elements of RICE that we're still using with this. We're, basically our whole thing is, let's just not completely knock out that inflammation. It's there for a reason, outside of, autoimmune diseases and so forth, different ballgame. But for this kind of acute injury stuff, that inflammation is important for the healing process. We want to maintain it in that Goldilocks zone. Don't want to completely knock it out. Don't want it to balloon up either. And I think with our active techniques, we can avoid that ballooning up thing that we all have, a reasonable aversion to. Early education is key. The active approach is the big thing. The action is the juice. We want people up and moving, and reinforcing the current research. So we would want to kind of open it up and hear from, folks that are working more on the medical side, like maybe this is kind of like, that's kind of sounding kind of niche and weird and new and that kind of thing. And so we would want to maybe hear from you about like, okay, well, here's a specific scenario. How would that actually be, managed? What would actually be different? And maybe I would open it up by asking the question, as opposed to like pushing NSAIDs, is there any reason where some of these acute injuries, is there any reason why we couldn't choose a different pain relieving drug if the patient really felt like they were drawn to it? Is there any feeling there, any thoughts that you guys have or things you've been exposed to? For example, is there any issue with using Tylenol instead of the ibuprofen just for that initial pain relief? Would be my question sincerely as a therapist. So there's a question in the chat about recommending brace or boot during the first 1 to 3 days. I think if you've ruled out Ottawa ankle rules, I don't think I'm really going to recommend the boot. I think that might be a little too much. As far as a brace, if that helps like their mental side, makes them feel like, oh, I've got some support here and I still feel okay, that's all right. I don't think it's an absolute necessity. I would think more about, just limiting the activities. Like maybe they've got, oh, I've got to go walk through the airport for Thanksgiving. Like, yeah, that's appropriate time, get some protection. Or maybe if they really feel like they need a brace, are they appropriate to have a single crutch so they can maintain that walking and mobility? But in a perfect world, we'd see them in PT, get them started on some exercises immediately, and we'd be able to give them more specific treatment guidelines based on their physical performance.
And I think
that
one other piece is with the brace and boot, just real quick, is we tend to like the wrapping just a little bit better, just because these braces and boots are easy to kind of rely on after that initial phase of healing's kind of gone down. There's nothing inherently wrong about a brace or a boot. It just has to align with the context. So that's a great question.
Yeah, and I think it just gets very person specific. I sometimes will joke with that stuff. Sometimes it's to protect others from them or others to them, right? So like that airport example is kind of just, hey, don't bump into me. I'm going through some stuff, but we don't want them to become reliant or cause harm again if they become dependent.
There's another question about topical agents, so CBD, Biofreeze, topical Voltaren, even though that's still an NSAID. Any thoughts about that?
I think those are preferable just because it's not a systemic application. Personally, I would be open to hearing from our medical team and kind of understanding what's the data say about how much the inflammatory process is really inhibited with those agents. I think that part of this comes back to education, and that in our culture, people are so geared up on the fact that I need to knock out pain. I shouldn't have any pain. I shouldn't have any inflammation. We can use it like in Europe, for example. I mean, it's a completely different approach. I mean, as far as I know, NSAIDs are not, you can't just go to Costco and get 300 pills. It's more controlled, and perhaps for good reason. So anecdotally, I would just say I'm more in favor of those agents as opposed to like, oh, well, let's do, 3,000 milligrams of ibuprofen every day from here on out, or whatever the current dosage is these days.
And just kind of going off what Ryan is alluding to, if patients are having to take that many oral medications, it's probably not appropriate for them to be doing the amount of strain on the area as they are. So I think that's what I try to remind patients too. If you're masking the pain in order to push through, it's probably not an appropriate step to be at. And then we can kind of backtrack and work our way that way versus, yeah, it's great. Take 2,000 milligrams of Tylenol, assist that with some ibuprofen and get walking or running. That's not an appropriate path either. So I take the more conservative route too and say, let your body tell you what you're capable of at this stage, and we'll work through it. So just an idea for me.
And that reminded me of something actually, and maybe like a big broader example, thinking about, coming up in the 90s, I remember it was like, oh, these cortisone shots are wonderful. Let's just throw them around like candy. And then it became more like, oh, maybe just 3 a year, that kind of thing. And what's the reasoning behind that? Because it can deteriorate the tissue quality for the very reasons, that underlying biology that Ben was getting to. So that's maybe the more extreme example, that inflammation is important for that maintenance of soft tissue quality. And if we completely knock that out, then there are some deleterious effects here.
If no one else has another question, I wanted to just throw to you and Erin and Ryan, just a quick question. In your own experience, in terms of pace of recovery for someone who does an NSAID, ice versus someone who weight bears right away or does ankle pumps. We're talking about that ankle injury. Do you guys have personal experience seeing that difference in speed of recovery? And if you could touch on that, maybe Erin, we could start with you if that's okay.
Yeah. And I think you're getting right into the research with that question, Ben, of like, we see it clinically weekly. So, I think we've all seen someone who, and this gets into the education piece of, and it's piggybacking off of what Ryan's saying, is understanding that movement and some